Hello. So I'm going to give my perspective on some of the advances in imaging, focusing on prostate cancer. So basically, I'd like to start out by saying that the data is clearly showing that PSMA is the most accurate and the best diagnostic test available. And this study is the ProPSMA study that was performed by Michael Hoffman from the Peter MacCallum Cancer Center in Australia that compared PSMA PET-CT versus standard imaging in a prospective manner. And you could see from the data whether it's accuracy, impact on therapy, or the certainty of results, that PSMA PET-CT performed much better than standard CT and bone scans. From the imaging perspective, I think it's pretty unequivocal that this is, again, the best test out there. I think the biggest question is with regards to access. And this is just a brief update on where we stand with regards to access in the US. So UCSF and UCLA, led by Tom Hope, has submitted an NDA. Tom Hope and Jeremy Clay have submitted an NDA that will hopefully be approved by the end of the year. Pending approval, gallium-68 PSMA 11 will be available only at these two sites. If other sites want to start producing it, they would have to file an ANDA. And again, that might take a little bit longer, but it'll be available for other people to hop onto in order to produce it locally, as long as they have the appropriate facilities. There is a company, Telix Pharmaceuticals, that is working on a cold kit, which basically allows radiopharmaceutical companies that have a gallium generator to use this cold kit and produce their own gallium-68 PSMA diagnostic agent, kind of like a shake and bake type approach. Alternatively, we have Progenics, who've supported multiple clinical trials, Condor, Osprey, that are looking at an F18, a fluorine-based PSMA agent that should hopefully be approved maybe mid or late 2021, and then be able to be commercialized soon after that. So we're optimistic that in the next year or two, there'll be much more widespread availability of PSMA-based imaging agents. So when we talk about the PSMA-based imaging agents, there's been some more discussion about the use of the tool in patients with initial diagnoses of prostate cancer. And this summary slide comes from Tom Hope from UCSF that was presented at ASCO this year virtually. And basically, it showed that PSMA 11 had a sensitivity of 40% and a specificity of 95%. The sensitivity of 40%, I think, looks low, but this is actually much, much better than any other imaging tool we've had in the past. So that is exciting. It also showed that patients with larger nodes, higher preoperative PSA, and higher Gleason score had increased sensitivity, which isn't surprising because larger nodes are easier to detect, more prostate cancer cells in there. Higher PSA, again, more disease burden, and higher Gleason score, more aggressive disease. Interestingly, 87% of patients with true positive disease had immediate biochemical recurrence after surgery. So all these patients went on to get surgery, but 87% of them who actually had true positive disease actually had high rate of recurrence soon after surgery, which then begs the question of the value of the test. And I don't think we clearly know what the optimal management strategies are when you deploy PSMA PET-CT at initial diagnosis. Biochemical recurrence is where I guess the data is most robust with regards to PSMA PET. But the performance data is just one piece of it. Really understanding the clinical benefit and the outcome benefit to using this tool is really where the money's at. And when it comes to oligometastatic disease, we're seeing more and more studies that are being published about the benefit of treating oligometastatic disease, whether it's the STOMP trial from PEDOS, whether it's SABRE Comet from, I believe it was Europe, multi-site trial from Europe, whether it's Oriole from Hopkins or Extend, which is a basket trial from MD Anderson. You're seeing more and more data that is showing some benefits to treating oligometastatic disease more aggressively. But I think this still needs to be developed further in order for more physicians to feel comfortable with that approach to managing patients using advanced imaging. We're going to shift gears and talk about some of the future applications of PSMA PET when it comes to therapies. And the idea of patient selection is absolutely critical. We've seen a lot of single-site trials looking at lutetium-177 PSMA, and you clearly see patients who respond, but you also clearly see patients who don't respond. And the question always becomes, why are those patients not responding? And I think imaging can really help us pick out those patients that will respond and those who won't. And this slide comes from Michael Hoffman from his therapy trial that compared lutetium-177 PSMA versus cabazitaxel. And what you're seeing is this novel approach to using PSMA and FDG PET-CT to help pick out those patients that might be the best responders for lutetium-177 PSMA. And based on this, they actually excluded some patients to actually undergo therapy with lutetium-177 PSMA. So the question is, do we just need a PSMA PET-CT to establish inclusion criteria for lutetium-based therapies? Do we need FDG only? Do we need both? Or maybe no imaging is required. And I believe there is a trial, I've heard of an alliance trial that is actually incorporating no pre-therapy imaging into their protocol. So that's an interesting idea as well, because we know that most patients with prostate cancer, especially in the hormone-sensitive setting, are probably expressing PSMA. Another area that needs to be explored is treatment response. We've seen this picture multiple times that shows a great response. And we could actually image the lutetium-177 PSMA, in which case it really puts into question the value of performing a gallium-68 PSMA PET-CT in these settings. So I think there might be some benefit into being able to image some of these patients in certain clinical scenarios. But again, I think this is another area that needs to be explored. So just in conclusion, I just wanted to say that we're really just scratching the surface. We're really just seeing the tip of the iceberg when it comes to the value of imaging in prostate cancer diagnostically and as a biomarker. And it'll be exciting to see what more develops in the future with regards to PSMA PET-CT. So thank you.